So thank you very much for inviting me to give this case. This is an interesting case that fused my scholarly interests, which is in endocrine ethics. If you look at your materials, you'll see my bio. I am a clinical ethicist with sort of classic humanities-based training. I have medical sociology as my background. My interest in endocrine ethics and thyroid ethics came about because I actually am a thyroid cancer survivor, although I did not have the type of thyroid cancer that we're going to talk about today. So this is a case where it's a rather complicated, unique cancer context, so I'm going to spend a little time just giving you the background. And let me just go back. We'll talk a little bit about the history of hereditary medullary thyroid cancer, which I will refer to as MTC, and the RET proto-oncogene, which is responsible for this type of cancer. We'll talk about classic dilemmas as well. So this is the thyroid gland, for those of you who are non-physicians, and this is the little gland that we're talking about that is causing so much trouble. What we know about hereditary medullary thyroid cancer, or MTC, it accounts for about 5 to 8% of all thyroid cancers. And by the way, thyroid cancer is now the fastest rising cancer in incidence, and it's particularly increased. Women are actually more at risk than men for traditional thyroid cancer. It's responsible for about 15% of all thyroid cancer-related deaths. If you've ever heard anything about thyroid cancer, you might know that it generally responds to radioactive iodine. That's in certain types of thyroid cancer, known as papillary thyroid cancer, follicular thyroid cancer, which do respond. Medullary thyroid cancer is different, and it does not respond to systemic radioactive iodine therapy. So there's actually no effective treatment, no effective chemotherapy. It's usually diagnosed in an advanced stage when the patient presents, often with tumor outside the thyroid bed, and surgery is not as optimal at that point as it would be if it were found earlier. And the other issue is that when it's hereditary, it's autosomal dominant and 100% penetrant. It is 100% penetrant, so if you have the gene, you are going to get the cancer. There's no question about it, although the age of onset is variable, but there are certain types of, it depends on the, on sort of where it is in the genome. We estimate the national incidence rate. We get about 3,000 new cases per year. So it has a prevalence of about 35,000 cases, and that's using 2009 SEER data. About 25 to 30% of MTC cases are hereditary, but we think that a lot of what is reported as non-hereditary or sporadic are actually now shown to be hereditary upon further analysis. So the data is not as reliable as we'd like. And it accounts for about 17% of all pediatric thyroid cancers. It's more than twice the rate in children as it is in adults. So in the genetic pattern for this cancer is that in 1993, that's when the germline mutations in the RET proto-oncogene were found to be responsible for familial medullary thyroid cancer. It can be part of, so MTC can occur as just familial medullary thyroid cancer, or it can be part of what is known as MEN, the MEN2 syndromes, which stands for multiple endocrine neoplasia, and there are two types. There's one subtype that's known as 2A and one known as 2B, and in these cases, it's the same mutations that also lead to medullary thyroid cancer. So what you would get is an M2A. It would develop along with another endocrine tumor of the adrenal glands, pheochromocytoma, as well as hyperparathyroidism. That would be an M2A. And you'd also get sort of for lack of a better term, sort of a bumpy tongue and sort of strange appearance of the tongue, which is in MEN2B, and that's rarer than MEN2A. We use the term hereditary medullary thyroid cancer to discuss either familial MTC or MTC arising from one of the MEN2 syndromes. And family members of positive index patients will develop medullary thyroid cancer with 100% certainty if they test positive for the mutation. So this is a very unique a very unique cancer context. It's not like there's a higher risk or a risk of 50% or greater. It is 100%, and that's what makes it a much more compelling cancer to deal with. This is a slide that comes from the NCI that just sort of shows you sort of where, sort of how this all works. Although I am not a geneticist, I will not deal with some of the details of all of this. But what I will say is that if you look at the American Thyroid Association actually has guidelines on how to treat medullary thyroid cancer. We do know that depending upon the exons and the codons, we do know that some children, if they test positive, are actually going to develop the cancer before age 5. So we can actually predict, with a rather astounding certainty of some of the age of onset. With others, it's a little dicier. There is a standard of care for all of this. So upon diagnosis of MTC, the index patient is always offered genetic testing to rule out the genetic mutation. So essentially what this means is patient comes to the doctor, it's usually an endocrinologist, and they're found to, they have a thyroid cancer of some sort. We find out that it's of the medullary type, and then they're referred for genetic screening to see if this is sporadic, or do they have the mutation. So if they're positive, they may represent a very large kindred comprising dozens, hundreds of at-risk individuals. And then the index patient is guided to formulate a family tree, begin the process of notifying family members of potential risk, genetic screening, etc. And family members of positive probands will develop, they'll develop it with 100% certainty if they too test positive. So when we find family members who test positive, they're offered a prophylactic thyroidectomy, which completely prevents medullary thyroid cancer if it hasn't yet developed. So in many cases, when prophylactic thyroidectomy is performed on positive family members, you can actually see that MTC has even started but is not spread outside the thyroid bed. That's occurred many times in the clinical scenario. And again, in positive children, the standard of care, as you'll note, which are stated in the American Thyroid Association guidelines, is to perform a prophylactic thyroidectomy before age 5, or as soon as possible if they're over age 5. This is just the standard of care. So the treatment is, so let's say you don't get to it in time and you just present. So the treatment is, first of all, you would try to surgically resect the tumor if possible. There is no effective what we would call tumoricidal therapies for MTC, so no effective chemotherapies. Life can be extended with one or two types of what we now call what are known as the TKIs, tyrosine kinase inhibitors. These are the really exorbitantly expensive drugs that a lot of people actually can't afford, but two of them have been approved for use, which are tumoristatic, so they can hold things at bay for a while. Not everyone's a candidate. If you're a candidate, you may be able to benefit from these drugs for a few years. It depends. There's a lot of side effects, cost prohibitive, so it depends. But that's what we're looking at right now, no good treatments for this disease. So the summary regarding the background is that it's an aggressive form of Thyroid cancer doesn't respond to radioactive iodine, challenging to treat at any advanced stage. It's 100% preventable through prophylactic thyroidectomy. Genetic screening can pinpoint an identifiable RET mutation in 95% of persons with these syndromes, and in 88% of those with FMTC, which is just the familiar medullary thyroid cancer without the MAN syndrome. We can prevent this in 90% of at-risk individuals with current genetic testing that's available right now today. So there are some gaps in the data and the management. We think that the incidence and prevalence rates underestimate the number of hereditary cases because they've been observed in many so-called sporadic cases. We actually don't have enough genetic counselors involved. They're often not used. Many physicians are incompetent to manage this adequately and do genetic counseling, but a lot of there's just a shortage in genetic counselors available. There's virtually no qualitative research that's been done in medullary thyroid cancer that looks at how genetic information is filtered or disseminated, and there's been no behavioral science research whatsoever in dealing with the fact that the uptake of genetic testing among relatives of patients with MTC is just inadequate and not well studied. So the ethical dilemmas in the adult setting, there's a lot of LC barriers to genetic screening, literacy, numeracy, education, et cetera. The positive index patient may decide not to disclose his or her test results to adult family members at risk. We think greater than 50% of index patients actually present with a thyroid mass. Up to 75% actually have a distant metastasis. So that tells us that they're not testing. We're not testing enough people. Access to genetic screening and insurance, are issues. Even when results are disclosed to at-risk relatives, many actually refuse prophylactic surgery. And again, genetic counseling is inadequate. In the pediatric setting, so again, it accounts for 17% of all pediatric thyroid cancers. 15% of affected families actually don't accept screening. They don't want it. They say they don't want to do it. Parents can refuse to screen their children. Many parents delay or refuse prophylactic thyroid surgery for their RET mutation-positive children. The harm principle, which Doug Diekema has helped to crystallize for everyone, can be invoked in these dilemmas. I wanted to say, too, that so all of these problems were theoretically imagined in a paper that I co-authored with Doug. I cornered him at an ASBH meeting to talk about this problem, and we developed a paper with pediatric ethics guidelines, and as the paper was in press, we got this case. So luckily, we actually had had thought about it. So the case was, we had 2 post-thyroidectomy MTC patients that were referred to the University of Kentucky Thyroid Oncology Program within the same month. And both were found to have exactly the same mutation, which was consistent with MEN2A. The patients were actually asked to provide family trees, so we went through the standard of care. And the reason why they were referred after their thyroidectomies is they had presented to their other physicians with thyroid cancer. They had their surgeries, and then we have a thyroid cancer program that saw them after their surgeries. One had consented to doing the whole thing with the family tree. The second patient declined. And when we actually looked at the family tree, it revealed that the second patient was the estranged sister of the other patient. 75 individuals were at risk. The majority of these at-risk individuals were children. This was a large Eastern Kentucky family, very dysfunctional. Half of them didn't talk to each other. Lots of issues. Obtaining contact information for the members of this large family was challenging. The male index patient had been estranged from his family for decades, and his daughter devoted a lot of effort to reach family members. So initial contact with the at-risk family members was made via notification letter, and I won't go into those details because I'm running out of time. After 2 mailings, multiple telephone calls, they were just unsuccessful in being able to contact these individuals with the one that was actually willing to do it. And an ethics consult was called, and I'm going to come back and tell you what happened, but now we're going to go to hear from the other co-panelists on this. Thank you.
Thank you, Sarah. So easy case that the law will weigh in on somewhat. So Doug suggested that I focus on 2 questions. Is there a duty to warn of the genetic risk, and does parental refusal of genetic testing constitute medical neglect? I had thought originally that we were going to have time for discussion, so you'll see kind of towards the end a lot of my questions are discussion questions that I hope we can talk about later, but we won't have time, so if anybody wants to talk afterwards, I'd love to hear your input on this. So where does the duty to warn come from? As most of you know, it comes originally in the law. It came from a case out of California in 1976, the Tarasoff case, where the court found a duty to warn an endangered party or those who could notify the endangered party. And they found that there was a need to weigh the patient-physician confidentiality against the public interest and safety. And what happened in this case is that the patient told his therapist that he intended to kill Tatiana Tarasoff. The therapist notified the campus police. The campus police detained the patient, Podar, and determined that he was rational, so they released him. The therapist went to his supervisor and said, "Is there anything else we need to do?" The supervisor said no. 2 months later, the patient killed Tatiana Tarasoff, and her parents brought suit. And the court agreed that there was a duty to warn. They focused on the dangerous potential conduct of the perpetrator, the interest of public safety, and that they really focused on the identifiable victim. So if there's an identifiable victim, you have to try and warn that particular person or somebody who could contact that person. Other courts have extended this duty to warn to all foreseeable victims. Where does this leave us with genetics? Well, there is a case almost on point. It had where the question was, does the physician owe a duty of care to the children of a patient to warn the patient of the genetically transferable nature of the condition for which the physician is treating the patient? And in this case, Pate was diagnosed with thyroid cancer at an advanced stage 3 years after her mother had been diagnosed and treated for medullary thyroid cancer. Pate sued Threkel, alleging that he had a duty to warn her mother that her children should be tested for the disease, and the court agreed. And the court, though, specified that the duty to warn is satisfied by telling the patient, assuming then that the patient would go on to tell her or his children. 1 year later, the New Jersey court heard a similar case, but they refused to limit it to the duty to warn to just the patient. They said in some circumstances, you may be required to warn the actual family members, not just the patient or the index case. In this case, Safer's father had died of colon cancer 26 years later. She was diagnosed with colon cancer, and she filed suit against his doctor, saying that he violated the duty to warn her of the risk to her health. And so the court did say it may be necessary to resolve the conflict between physicians' broader duty to warn and the obligation to the patient to say nothing. So you may have to go beyond the patient to make sure that family members know. Both of these cases were summary judgment cases. They did not go to trial. They were before the trial. In the Safer case, actually, when it did go to trial, the Safer lost because the evidence came out that she had a rectal exam at age 10, and the court and the jury agreed that that was probably indicative that they had been warned by the doctor. So just so you know, the end of that case wasn't that the physician was sued successfully. I put the Malloy case in here. It's not exactly on point, but it's one of those genetic testing cases where the court said that the physician's duty regarding genetic testing extends beyond the patient to the biological parents who foreseeably may be harmed by a breach of the duty. And in this case, there was a 3-year-old girl who had been developmentally delayed. She had a number of tests done. The physician said, you know, we should test for Fragile X. Everybody thought that the test had been done. All the tests had been negative. I think you can predict what's going to happen. Nobody tested for Fragile X. The mom went on to have another child who was also delayed. That child was tested by a different physician and found to have Fragile X. So that physician said, you know, everybody should get checked out. And then they found out that this child did have Fragile X. And the parent sued, or the mother sued, saying, had she known that she was a genetic carrier, she would not have gone on to have another child. So what to do with this information, and what do we, because it seems like there's a lot of conflicting information. From there we have HIPAA that says we can't disclose without consent, and yet we have these cases that say you ought to, you must inform or warn without consent. Well, Amy Foster in 2010 law review article, Baylor law review article, said that she called for more encompassing federal and state policies about this. She cites that PATE and SAFER were actually pre-HIPAA, but that ambiguity still persists, and there are disputes in the community about whether you have to warn. There's informed consent. Should we include the information to patients that if they're going to be tested for some genetic trait, that we will have a duty to warn their family members if they test positive? There's questions about the accuracy of these genetic tests. I know we're talking about FMTC here, but there's lots of other tests, and not all the tests are as accurate as the one we have here. And she argues that confidentiality laws should err on the side of caution when protecting genetic information. Then there's the issue of whether TerraSoft type warnings really apply to genetic information disclosure. In TerraSoft, the court really focused on the person's conduct and public safety. And it seems to me that genetics is something different. The patients cannot put existing relatives at risk of becoming carriers of genetic mutations, is Foster's point, and I think it's a good one. And disclosure is irrelevant to whether a relative has the gene or the mutation. They're not communicable diseases. It's not the same thing. So the language and the linguistics that we're using in these types of cases we're using the same word to describe two, I think, different situations. Are we using the duty to warn as a tool to obtain what we as health professionals want to accomplish or think is best? Do we really mean duty to warn? Other writers have used other language that I think might be more on point. Sonia Suter in '93 talked about the privilege to disclose, and we might have the privilege to disclose under certain conditions. The duty to share has been mentioned by Parker and Lucasen, and they compare genetic information to a joint bank account. And the genetic information is there, one person may access it, but it really should be open to other family members as well once that information is there. Lau disputes this and says he's against the default of familial sharing because he says there's so much variance among the genes that not everybody should have access to all the information. The duty to rescue was mentioned by Laura Beskow and Seattle's own Wiley Burke, but that was in a research context. Do we want to extend that maybe to the clinical context and call it that? Duty to disclose, duty to protect. I think when we talk about duty to protect, there's also a social authenticity component. Do we have other things that we have a duty to protect children against that may be more important than some of these genetic diseases and tests? Power to warn, Sarah has mentioned that. That's another, given certain conditions, do we have the power and the moral authority to warn under certain circumstances? Do we have an obligation to notify? So the outcome of a duty to warn or something else may be the same, but the language we use makes a difference. Does parental refusal of a genetic test constitute medical neglect? So I talked to a few people about this, including Lynn Sheets, our medical director for child advocacy at Children's Hospital, Teresa Roeder, who is a guardian ad litem and family lawyer in Madison, Wisconsin, and Janet Dixon, our corporate counsel at Children's Hospital of Wisconsin. And they said they all agreed that you really need to focus on these two things. So what defines neglect, and then what are the facts? I put up Wisconsin's neglect statute because I think they're all pretty similar. So as you read it, do you think that a family member's failure to obtain genetic testing, does it fit this definition? Should it, given the historical context of neglect and what we've used that for? So what are the facts? What is the risk to the child? What is the certainty of that risk? Here in the FMTC case, if the child has the gene, it's 100% penetrable, or if a relative does, that they have a good chance of having it. What is the gene that's being tested? How accurate is the test? Do we need to retest or get a second opinion? Does it depend upon the machine that's reading the test or the person who's interpreting the data? Is effective or treatment available? Should we consider the reasons parents refuse to test? Do their reasons matter? Might these reasons reflect parental understanding or lack thereof, or important values that they hold? If a parent is inarticulate about why they refuse the test, does this invalidate their response? Carol Jenny in Pediatrics had a number of factors to consider when thinking about making a report of child neglect. I have put the word test in where she used healthcare. So is there a risk of harm or risk of harm because of the lack of the test? Does the test offer significant net benefit? Does the benefit of the test significantly greater than the morbidity? Is the access to the test available and just not used? Does the caregiver understand the medical advice that is given? And this may be, when Sarah and I talked about this case, this may be kind of what's going on here. So what's the process? One of the things that was made clear to me is that physicians and nurses don't make the determination of neglect. If they have a reasonable suspicion that something may be neglect, they have to report it. And it's really up to CPS and then the legal system to decide whether or not that exists. So here they make a referral to the Child Protective Services, and then CPS decides if the child is in need of protective services. If they are, then the parent, they decide whether the parent is charged with neglect. A guardian ad litem is appointed, and they may override the parental decision. And it's important to note that there's potential trauma to the child and to the family because of this intervention. There may also be circumstances where you could call the judge to get an order, especially for a test like this where there's so much clear data about it. But it's usually not necessary for something like this with a genetic test because there's not a risk of imminent harm to the child that we know of. So it's unlikely that a judge is going to take the call and do something right away. Another solution may have been to negotiate with the parents, and if the parents would consent to having themselves tested, there may be no need to test the child if the parent is negative. I had one medical geneticist note the case in Nebraska. They said, well, of course it's child neglect because remember that case in Nebraska where the child was taken out of his home and tested? So I read up on that case, and the Supreme Court actually said in this case that the failure to test for the mandatory newborn screening alone does not establish neglect. What's different about this too is it was part of a mandatory state newborn screening. The child had been born at home, 3 weeks old. The state got wind that he had not been tested, so they came in, actually removed the child from the home for 5 full days. And the court questioned why the CPS didn't return the child after taking the test, which arguably could have been done in the home. So what do you think about the language? Is it really a duty to warn, or is it something else? One author cited that estranged family relationships are not unusual, so maybe we should start thinking of the norm as being some family member is going to refuse to share the data. So maybe we should think of a system whereby that's kind of the norm and not something that we think is unusual. What are the harms that may come to the child? There may be physical, emotional, social, financial, present, and future. Does the parental refusal constitute neglect? Are there social duties beyond enforcement? If the state is going to enforce that these testings be done, what else? Do the parents have to have access to the testing? Do they have to have access and testing to genetic counseling? Do they have to have access and funding for the surgery and any follow-up care? What about any negative effects to the child because they can't get insurance later on, life insurance? What are some of the social values that are going on? Because I think if we apply this to FMTC, we know there's going to be, as we obtain more tests that are increasingly accurate and whatnot, we know we're going to extend this to other genetic testing. So I think it's important as a society, if we're going to say, yes, okay, you can force the testing, we have a responsibility, on the other hand, to these children. Are there social safeguards that must be in place before we mandate tests over parental objections? So do we want to secure future goods for the child, such as health care, employment, mental health care? How do they relate to what disease they might have, the coping? So a solution is newborn screening for a limited, defined amount of genetic conditions, the answer. I would say that we should have specific inclusion criteria and provide for protections for the child and resources, and make sure we have adequate social safety net to counter any potential negative financial or health effects, including stigma and hireability for the child. That's it. Thank you.
Great, thank you. Well, I'm going to be talking about a slightly different perspective on this case, which has to do with something that Kelly mentioned at the end, which is sort of what happens when we have more genetic information available than just the kind of genetic information that's in this case. And so I titled my talk, We're Not in Kansas Anymore, which is not, that's Wizard of Oz, not about Kansas or Kentucky. Thinking about how pediatric genetic information changes in the exome and whole genome sequencing era. So I'm going to start with a sort of revised version of the case with some twists on the ethical questions and challenges that might be placed, because I think this is part of what we do in clinical ethics as we try, and what we're trying to do this weekend is try to learn from the cases that we have that present themselves to us and think about how we can extrapolate those to other kinds of cases and policies that may come before us and our institutions in the future. I'm going to go through a little bit what I think is sort of the old or existing paradigm of genetic testing and how things are changing, and there's a new paradigm with some different components that are going to challenge us ethically. I'm going to really very briefly, too briefly, talk about two new sets of guidelines that came out this year. One from the American Academy of Pediatrics on genetic testing and screening in children, which Lainey actually led. And then the American College of Medical Genetics, or ACMG, guidelines for the return of incidental findings from clinical sequencing. And there's a lot of debate, and there's really no consensus on this yet, but I want to sort of raise it to all of you in thinking about how cases like this may challenge the way we think about this information in the future. And then talk a little bit about questions for possible future ethics consults that might come out of genetic testing. So a different twist on the case. Imagine that instead of the case that was presented, instead a 3-year-old boy with unexplained seizures and developmental delay undergoes exome sequencing for diagnostic purposes. And this is actually exactly the kind of case in which exome sequencing is currently being offered in a lot of clinical institutions, including our own. And among the results that come back for this boy include a known pathogenic mutation in RET for MEN2B, as was discussed in this case, for which a thyroidectomy before age 5 is recommended, a known pathogenic mutation in BRCA1 for breast cancer, and the Delta 508 mutation in CFTR for cystic fibrosis. And you may think that this is far-fetched, but I can tell you from having worked with a lot of exome sequencing data over the last couple of years, it is not. And of note, you will notice that none of these explain his seizures or his developmental delay. So the parents, not surprisingly, are currently overwhelmed by their son's condition and getting him the services and treatment he needs. He also has a healthy 5-year-old sister, 6 first cousins under the age of 21. His aunt and his uncle are planning in vitro fertilization in the near future, and his maternal grandmother died at age 50 of breast cancer. So that's some of the background information about this case, some of which the clinicians may or may not be privy to, and this is supposed to be a picture of a family reunion. And the kinds of complex other kinds of health conditions that family members often face. And this is something that's been common to genetics and genetic risk for disease for a long time, obviously, and that clinicians have had to face, and genetics counselors as well. So I think the questions that I sort of want to ask here related to the case are, what are the obligations to tell the patient's parents or to offer to the patient parents the identified changes and the genetic changes? And are there different obligations for the different changes? Obviously, the RET mutation has specific implications for the clinical care and prevention of the child who was the one who underwent exome sequencing. The BRCA1 mutation and being a carrier for the CFTR mutation that causes cystic fibrosis have really not probably implications for this particular child, but may have clinical implications for the rest of the family in a particularly important way that they may want or choose to act on in the future. And how does this information get presented to families? How can we allow families to make informed decisions about whether they want this information? And then if they get this information, how can we help them use it in an appropriate way? Kelly talked a little bit about the duty to warn or other ways to think about that. Does the duty to warn, or whatever you want to substitute for warn, outweigh the right not to know, or the right to have the autonomy and the ability to make choices about what you want to know? And is the duty to warn the same or different for different kinds of results and different kinds of people in different sorts of situations? If this were an elderly person, would the implications of those results and the duty to warn be different, for example? What are the physicians' or the parents' obligations to tell extended family members? I think the cases that Kelly talked about were very interesting for some examples of sort of where courts have sort of taken different positions about what parents or physicians may or may not be obligated to do. And I think this is sort of evolving and unclear. And the nature of the kinds of information that will become available through exome sequencing as it becomes more broadly applied will raise these questions to even a greater degree than has happened up to this point. And really, as from an ethics standpoint, preaching to the choir here, it's really about balancing autonomy and beneficence and non-maleficence, and there are probably some justice issues too. But thinking about how we weigh all these things and how we think about ways to give parents and families choices about this information, and then ways they can use this information if they choose to get it. And I think part of this is what I was talking about before, about the old paradigm of genetic testing versus what I think is a new emerging paradigm. The old paradigm was that a clinical indication or a family history precipitated a genetic test. And genetic testing usually focuses on a specific mutation or gene or parts of a gene, or maybe a small number of genes or a panel of genes, for example, from some cardiac conditions. And in-person genetic counseling takes place usually, not always, about the meaning of the test and the recommended testing for family members. And then individuals are given choices about whether they want to get that test and how they're going to make meaning of information when they get the test result back. In many, but not all situations, it was unlikely or impossible to identify sporadic mutations in people who had no symptoms or no family history. And I think under the old paradigm, with the exception of newborn screening, very few people had genetic testing or information available for themselves for the vast majority of genes that we might know information about or be able to know information about. And newborn screening for rare traits that were actionable in infancy were associated with severe imminent clinical consequences if untreated. So newborn screening is really focused on one particular category of conditions. And when public policy has been made about newborn screening, both in terms of the federal level and the state levels, that's been the sort of paradigm for how to think about when you might want to compel through policy individuals to undergo genetic testing or genetic screening, and there are some very good reasons for that. I think in the new paradigm of genetic testing, not genetic screening, exome sequencing and whole genome sequencing may be the cheapest, most effective test for many genetic conditions. It already will be cheaper to do an exome than to do some of the panels for some of the cardiac conditions and possibly some of the other conditions as well. And what the sort of bell you can't unring component of this is, all clinically important and actionable results will be identified in one test that you are doing for a specific purpose. It will be possible to identify sporadic mutations, for example, sporadic mutations in RET associated with the kinds of thyroid cancer that we're talking about, where you don't inherit it, but the child has it as a sporadic mutation. And the benefit and actionability sort of framework may have longer-term implications for prevention, surveillance, and treatment. We're not just thinking about what this information might mean now, but what it might mean in the future for the child or for the patient, but also for the family members. I think in general, in the future, more people will have this kind of information, all possible genetic testing information from exome sequencing. Obviously, it's going to be a long time, maybe not a long time, but it's going to be a while before it comes standard. But I think it's going to be many more people than we're used to when we're thinking about the implications of genetic testing and genetic information. There's already discussion, although obviously people who are familiar with newborn screening will realize that it moves incredibly slowly, but I think there's a potential expansion of newborn screening and prenatal screening. In particular, there's been several demonstrations that exome sequencing can be used in non-invasive fetal genome sequencing, where you actually sequence the fetal DNA from the mother's blood as early as 8 weeks to identify potential conditions, and you find out, again, all of this information. So the amount of information, the kinds of information, and when we know it will be much greater for many cases and many individuals. Again, the old paradigm for pediatrics is that pediatric testing is only for conditions actionable in childhood, and there are some very good arguments, which Lainey has outlined, and why that should still be one of the sort of general overall guiding principles. And you choose to test for a specific condition based on a family history, or I should say, or symptoms. And the focus is really on the right not to know and the right to an open future, particularly for adult onset conditions or conditions for which there might not be any action, or conditions for which there may be results for which there may be uncertainty about what they mean. Genetic information, I think we've thought about it in the past as sort of more rare and associated with rare conditions, and really potentially stigmatizing, because there is a history with some genetic information, particularly with sickle cell disease and other information, as being potentially stigmatizing. And so we've been very cautious about this, particularly in children. And we've also thought of genetic information as infrequently actionable. I think MTC is often put as the sort of exception case where there's something to do, and a lot of other genetic information is purely diagnostic or related to reproductive risk factors or confirming something that you already know. This is the way we've thought about it before. I think now we're kind of shifting, and a child undergoing testing or exome sequencing may end up being the mechanism by which a range of potential duty to warn results may be identified, whether you want to or not. So we have to think about that when we think about policies and we think about how we're going to deal with this information. Genetic information, I think, will increasingly be viewed like other health information, like family history and health history, as a tool for prevention and treatment, and also something about which families and parents should be allowed to make choices about. I think genetic information will be more frequently actionable, both for a child and for a family. I think there will be maybe not as many things that are 100% penetrant, like mutations in RET, but I think there will be more information about which there's something that can be done, which may have different obligations and different duties associated with it. And genetic information, I think, and this is where most of my work is focused now, can be viewed as a resource for the patient and their family to be accessed over time, rather than at a single point in time, according to the patient and value preferences and values. And I think we really need to focus on how to give patients and families, whether it's an extended family that's estranged or whether it's a family related to a child who's getting information about unexpected conditions, the ability to make informed choices about whether they want that information, the ability to change their mind over time, and the ability to know what to do about that information, and hopefully a system that will support them being able to act on the information if they choose. I just want to briefly mention these two guideline papers that came out recently, and I recommend that you read them if you have the opportunity. The American Academy of Pediatrics, as I said, with Lainey's leadership, published some long-coming guidelines on update on guidelines on pediatric genetic testing. And I just want to highlight a couple of interesting points from the piece. Decisions about whether to offer genetic testing and genetic screening should be driven by the best interest of the child, and I think that will be very much in the theme of what we've talked about today with the other cases. Predictive genetic testing for adult onset conditions generally should be deferred unless intervention initiated in childhood may reduce morbidity or mortality. But again, this is talking about a choice to test for an adult condition, like, for example, certain kinds of cancer or other kinds of things, not necessarily a situation where you have all that information available. And specifically, Lainey can correct me, but I don't think that the exome sequencing was sort of one of the main areas that the committee chose to focus on in their recommendations. And finally, results from genetic testing of a child may have implications for parents and other family members. And again, anyone who works in genetics has been dealing with this for decades. Healthcare providers have an obligation to inform parents and the child, when appropriate, about these potential implications. Healthcare providers should encourage patients and families to share this information and offer to help explain the results to extended family or refer them for genetic counseling, which I think is very, very relevant to the original case that was described. Somewhat ironically, perhaps, the American College of Medical Genetics came out with guidelines on sort of overlapping, but not exactly the same issues, about how to deal with incidental findings from exome sequencing, like the ones that I showed you in this sort of twist on the case in the beginning of my talk. And basically, they listed, they had a group review and come up with a list of 56 conditions. As an aside, the paper says 57, but one of them is a somatic, so it's really 56. 56 conditions with mandatory reporting. And they call those conditions those most likely to be verifiable by other diagnostic methods and amenable to medical intervention based on current evidence and the clinical consensus of the small group of people who are on this working group. And so essentially they're saying that people should not, who get undergo exome sequencing, parents who have their child undergo exome sequencing, like the case I told you, should have no choice. And these results should be mandated for reporting by the lab and by the clinician, and the clinician actually has the entire responsibility to do that entirely by him or herself, whether or not they have a genetic counselor and the ability to do that. And they say reporting these incidental findings to the ordering clinician will offer the clinician, an appropriate consulting clinician, the opportunity to reevaluate the patient's personal and family history and consider appropriate surveillance or intervention. I think very much like this case. But I think there's something important here about the sense that this is mandatory and that there's no choice being offered. And there's also something important about the fact that how are these 56 conditions chosen? What are the limitations of that? Does this really encompass too much or too little? And where are the boundaries of what we might consider to be mandatory for reporting in certain situations, whether it's to the family or to a broader extended family? And they specifically also said, much to create much controversy among ethicists working in the field, that there was an obligation to return actionable adult onset results found in children, which is in contradiction to both the previous and the current AAP guidelines. And they said at this moment in the evolution of clinical sequencing, an incidental finding relevant to adult disease that is discovered and reported through clinical sequencing of a child may be the only way in which that variant will come to light for the parent. And I think a lot of the disagreement in this situation is around this issue of are you looking or are you not looking? Are you screening or are you not screening? Do you just have this information or did you have to somehow make a conscious decision to go look for it? And there's a variety of opinions, and I have some, and many others in the audience probably have other ones. But this is where the crux of the debate is how much do you know and what obligations do you have to report that and explain it either to the family or to extended family members as well. And just to list what the pediatric conditions were on that list of 56 conditions, these are the pediatric conditions. And the reason why I must say this is these were chosen with a fairly high bar, I think, for how actionable they were. I highlighted the MEN ones and the FMTC ones, but I just want to show you that there's more than that here. And so I think, if you were thinking about carrying some of the conclusions about RET and MEN to their logical conclusions, you might have a longer list potentially, and this has both practical and ethical implications about how we might actually do this. So in conclusion, just wanted to sort of introduce to you some of these emerging controversies that this case sort of gives a window into, and that this presented case may be the tip of the iceberg. Children may be the source of important clinically information and actionable results about themselves and their nuclear and extended family members, but it's not really clear what we should do about that, particularly if the nature and volume of that information might be quite large. There are many conditions and results that may fall into this category, which complicates the consideration of the ethical and practical solutions. I think we need, and this is what I work on, so I have a bias here, empirically tested tools and approaches for educating families about genetic information and implications so that they can actually make informed choices and so that we can respect their autonomy and allow them to make choices about that information. I think actionability and duty to warn may have less to do with penetrance and urgency and more to do with the severity of the outcome and the availability of the interventions. And this might be the topic of a whole nother talk, but I'm not sure that RET and MEN are actually so exceptional. And we may need to think more broadly about what that means, regardless of what we think should be done about it. And as information about genetic results is evolving and improving, disclosure and results management may no longer occur at a single point in time. It may not be one letter you're sending to a family. We may need to have dynamic ways to communicate with family members and patients over time about the information. I just want to acknowledge that I work with a lot of people in a very diverse interdisciplinary group with funding from NHGRI to actually study these issues. And I think, as Sarah said, and Kelly said, we may not have time to discuss now, but I would be happy and interested in anyone's reaction at the break. Thank you.
So I'm going to take the remainder of the time to tell you what happened. We'll just get my slides up again. Okay. So I'm going to not cover much of what's in the remainder of my slides, but just to tell you, so the ethics consult and recommendations. So we invited legal to the consult about whether we could, in this case, breach HIPAA to warn family members directly for the second tree. A pediatric ethicist from another institution was also asked to teleconference in on the meeting for an outside opinion because we wanted to make sure we were getting sort of a little bit more of sort of a 360 view. One of the ethics consultants on the case was a doctor from Eastern Kentucky, and it was her strong recommendation that the letter was deemed to be too complex. And a revised notification letter was written at an 8th grade reading level. When we say 8th grade reading level, the letter went back and forth a few times before it was considered to be sort of at a level that family members might understand. And the letter was sent with a bunch of 5x8 copies of the letter so that family members could further distribute to other family members. And then this was all done by the endocrine fellows who were dealing with the case directly. And then there was a telephone follow-up where they contacted the family members, asked if they'd received the letter, what they understood, et cetera, et cetera. There were not a lot of socioethical barriers that were revealed. There was lots of family conflict. A lot of people said they didn't have time, they were too busy. Transportation was an issue. There was an aversion to blood tests. There was a claimed indifference of the primary care physician where they were actually given wrong information by their primary care physician about MEN2A and told that they didn't need to get tested. Cost was an issue. And ultimately, about 40 hours of unreimbursed physician and staff time were used in these efforts to actually notify at-risk. By about 12 months after the presentation of the index cases, about 51% of the at-risk family members had actually been warned. It resulted in 31% of the at-risk members being tested, a total of 40% of them eliminated from the at-risk population because they actually tested negative. 17% of the at-risk population tested positive, and the majority, 57% of the family members who obtained the genetic testing were tested outside the facility, so there's not a lot to know about the follow-up. The endocrine fellows who were presented with this was sort of their first major sort of ethical conundrum, and they actually, our institution presented this at the Endocrine Society conference, and these are some conclusions that the physicians themselves came to. They did feel that they took all of the appropriate, effective efforts, of screening family members. They did all the right things. They spent, extensive effort in trying to fulfill their duty to warn. And incidentally, the legal team felt that we didn't have. They didn't feel that we could go ahead and warn outside of sort of the permission window. That we couldn't just contact family members directly, that it was only if they were receptive, to the letter and that sort of thing. Ultimately, they felt that the barriers to genetic screening were actually beyond the resources of the medical practitioner in the context of certainly in any private medical practice. They felt that, in a large institution where we actually had all of these individuals available, they still felt that they were unable to, there's just not the time and the resources and the individuals, to spend all of this time. They felt that, when you sort of add up all of the unreimbursed time and labor, practitioners are not willing to go through this, and that this really needs to be more of a public health issue. The high physician burden required for family screening and testing for FMTC is similar to that which would be needed for tuberculosis, HIV, syphilis, which are performed by public health departments. A notifiable disease is defined as one which regular, frequent, and timely information regarding individual cases is considered necessary for the prevention and control of the disease. And so the practitioners involved in all of this came to different conclusions and thought that this was really more of a public health issue, and that the responsibility and the burden of warning was so vast, especially in families that were this large, it was beyond their scope and beyond their resources. I'm not going to go into proposing a solution, but what I will do, I just want to go to my conclusions. So hereditary, obviously this is a different clinical context than other hereditary cancer syndromes, and I think Holly nicely summarized where we're going with a lot of these, when contexts are different and the distinctions between mandatory return of results. And I think that, when penetrance is significantly less than 100% and the genetic test can yield ambiguous results, the effectiveness of perceived benefits of treatment is unknown or has side effects. This is not the cancer we're talking about. This is not that context. Even with the unique features of hereditary MTC, many socioethical barriers prevent adequate genetic screening. So if you're even using a reasonable person standard, when we know that there is there isn't enough uptake of genetic testing, then there has to be, there are obviously lots of barriers to testing that we still don't know a lot about. I think if we assume 5 unscreened family members, at risk for each, 1,000 positive newborn screens annually, we could identify, prevent 5,000 cases of these annually. So I have made the, if you look at the second reference, came out in 2011 in the International Journal of Pediatric Endocrinology. I co-authored with Doug Diekema the first pediatric ethics guidelines for hereditary MTC. I'm currently on the Medullary Thyroid Cancer Guidelines Committee for the American Thyroid Association. I'm authoring the ethics section, and one of the proposals is to actually refer to this document and adopt it in the guidelines, although we'll certainly be adding new information as a result of all the new rethinking I'm doing in light of my discussions with Holly and Kelly. And I think that it's time to maybe think about this as involving public health in terms of resources. I think that that's about all I have to say, but again, we're happy to talk to you after the concluding remarks for the conference. So thank you very much.